it's my pleasure to chair the last session of our meeting, our two-day meeting. In the last session of today, I get the last session again. And again, it's exciting stuff because we're talking about data and surveillance and evaluation and all those fun things that, you know, really inspire us all. So I'm just going to launch straight into this. We've got a series of 15-minute presentations evaluating some of the work that we've been doing as in ECA Australia. Jess Howell, who is on the schedule, unfortunately can't join us in the room today. She's but she will be joining us on Zoom, and I'm sure that will all go completely seamlessly. And also, people's schedules that they had on the tables, I think, might have been an older version. So we're actually starting off with Yumi Sheehan. There's Yumi, who will be talking about the prison education project that I'm also proudly a part of and involved in. But Yumi, yep, absolutely.
Thanks, Mark. Hello again. So I am actually talking about an education program today, which doesn't quite fit in with the evaluation and surveillance, but it was a last-minute addition. So sorry that it's not quite fitting in with the topic of this session. But I am really excited to present some work that was funded by co-funded by the NHMRC, by AbbVie, Gilead, and we also had some funding from ECA, ECA Australia. So just a little bit of background about the National Prisons Hepatitis Education Project, which we call HEPED. So prisons, we know that there's really high prevalence of hepatitis C in the prisons. We do have well-established hepatitis services in the prisons in Australia, which is really great. And DAAs are available to people in prison. But we do know that we still need some further strategies to try and find everyone who has hepatitis C and engage them with services, because whilst we do know that there are lots of people who are getting treated in prisons, there's still only a proportion of people who actually have hepatitis C and who need treatment. So one of those strategies that we have identified is the provision of education. So the HEPED program, the goal of the HEPED program is to develop, deliver or implement, as well as evaluate a prison-focused hepatitis C education program. So that's a hepatitis C program that is prison identifiable. It has prison characters, it has prison settings and prison-specific information for the Australian prison sector. And this education program is trying to target the prison sector as a whole. So not just the people in prison, but the correctional officers as well, and all of the healthcare providers. So we're looking at a whole of prison approach to education. And I guess the goal of the education, or the focus of the education, is really to try and overcome some of the key barriers that remain in engaging people with testing and treatment. So these are most notably lack of awareness of hepatitis C and its treatment with DAAs, and also trying to address some of the stigma and discrimination that's still lingering around in the sector. And we've developed this education program within a public health literacy framework. So we're looking to improve the knowledge, attitudes, and capabilities, or the competencies surrounding hepatitis C for the prison sector as a whole. So this is quite a large project that's been ongoing for a couple of years, actually, and a lot of the people in the room today are involved in or have been involved in the project to date and will be involved going forwards. But just a bit of an overview of what we've done to date. So the first phase of the project, we conducted a national needs assessment and scoping exercise. So this is where we conducted mixed methods interviews with key stakeholders from the sector nationally. And we were really trying to identify some of the gaps in the knowledge, attitudes, and capabilities. So that's the health literacy, as well as identify some of the barriers and potential solutions to education delivery, but also engagement with hepatitis services for people in prison. And what we found I won't go into too many of the details because that would be a whole nother presentation. But what we generally found from these interviews was that there is widespread support from the sector for prison-focused education programs. And that's because there are in some jurisdictions across Australia, education that's happening in the prison, but there are occasions where there are community-based programs that are just being utilised in the prison sector, so they don't have that prison-specific kind of setting or content. So there is general support for prison-focused education, we did identify that there were gaps in the health literacy of those 3 target audience groups of the people in prison, correctional officers and healthcare providers, so there is room for improvement there. So following on from the National Needs Assessment and scoping exercise, we established 3 national steering committees, looking at, one for each of those target audience groups. And those involved key stakeholders from the sector, people from those target audience groups as well. So we really tried to make those national steering committees really representative. The goal of the steering committees was really to advise on the design, co-develop some of the resources, actually all of the resources and the learning objectives and whatnot, and also come up together with a delivery plan of how we're going to roll this program out. So we conducted 4 rounds of consultation, both meetings and lots of emails back and forth and lots of consultation phone calls and whatnot. And we resolved, each of the steering committees resolved that rather than having a traditional style of education, so that's like quite a didactic presentations and classroom style setting, actually trying to be a little bit more innovative and focusing more on multimodal resources. So not that classroom style activity, you know, you have infographics or discussion sessions and information booklets and whatnot. And also really important to have some kind of a peer education element. The steering committees also resolved that the messages and the resources needed to be really short and really sharp and clear, with simple messaging and low literacy, because we know that the people in prison and also the correctional officer populations have fairly low literacy and low health literacy. So together we co-designed this education program, and by that I mean that we came up with together with the learning objectives for each of the programs, the key themes and the topics, the characters and the storylines, and the implementation plan. So I'll run you through some of what we have developed. So the first stream of the program is for the people in prison, and the overarching the message of the education program as a whole that we've come up with is let's talk about Hep C. So that message kind of resonates throughout each of the different streams. For Hep, we also have specific bylines for each of the target audience groups. So for people in prison, it's let's talk about Hep C, test, treat, cure, prevent, it's simple. Some of the key topics here are really looking at the simplicity, trying to raise awareness about simplicity of testing and treatment, prevention and harm reduction, and mental health and personal well-being. And the modalities here for this program are a series of short animated videos, some comic books, information booklets, discussion sessions, and also a peer education program. And these 2 elements, the discussion sessions and the peer education program, are really key to this stream of the program. This is an example of some of our resources for the program. So you can see we've got some comic books, treat and repeat, it's simple, you know, talk to your mates, really just trying to get everyone, equip people with the confidence or the skills to just be able to have a conversation about Hep C. We've got some video animation, some posters that will be put up around the prisons, and an info booklet. So for the correctional officer resources, the message here is let's talk about Hep C, stop the spread, reduce the risk. And the goal for this program is really to, I guess, highlight the benefits of addressing hepatitis C amongst this population from more of a security perspective, or, you know, why is it important to me as a correctional officer, or how is this relevant to me as a correctional officer? So we've really kind of taken a safety perspective for this program. So the key topics here are safer environment. You know, if we address Hep C, it makes it safer for everybody. And it's, you know, it's a great idea to address Hep C. So also testing and treatment services, testing and treatment itself, so what's involved, and really trying to address the stigma and discrimination amongst this group as well. Very similar modalities for this group. Again, really trying to push the discussion sessions, really equipping people with those skills to just open up a conversation. There's also a peer champion program as part of this stream. So we're looking to identify some key people amongst the correctional officer population, train them up, and really have them lead on the delivery of some of the discussion sessions and getting all of their colleagues engaged with the various resources of this program. And here are some of the resources for our correctional officer program. We do also have a short online module for the correctional officer program. It's a choose your own adventure kind of module. So people get to shape their own story, which is a little bit different from, I guess, you know, your traditional style of online module. And the healthcare provider resources here. So the theme is let's talk about Hep C, participate, prevent, eliminate, or PPE. And the goal of this program is not necessarily to upskill an entirely new hepatitis workforce. It's really targeting the healthcare providers that are not currently working in the hepatitis C space. So just to raise awareness and give them the skills and the confidence to address Hep C if it comes across their plate, but more so actually just to encourage all of the healthcare providers that any interaction with a patient is an opportunity to either address or refer to the hepatitis services. So really just trying to raise awareness amongst all of the key players, actually all of the people physically in the prison setting. And the key topics here, again, simplicity of testing, treatment, prevention and harm reduction, more about the hepatitis services and how they actually work in the prison. So we're going to have tailored information specific to that prison, because we do know that it varies across prisons and jurisdictions, and also focusing on the health and well-being outcomes of the people in prison themselves. Again, very short, similar modalities for this group, short animated quizzes, videos, online modules, step-by-step guidelines that have blank spots so that we're really trying to tailor it to the setting. You know, who do we speak to if we need to speak to somebody about hepatitis C? Who is the key champion in this prison, and how do we actually do this in the prison? So you can see here on the right, left, the infographic with the blank spots and some of the other resources for this program as well. We've also going to create some print resources and merchandise just with, with our key messages, so that it just continues to, the message just continues to be spread throughout the prisons. And how are we going to actually deliver this education program? Because it's not a traditional style of education. And so what we're proposing, or what we've planned to do, is to deliver in an opportunistic education style. And so I'll use the prisoner program as an example. So we will upskill the peer educators in the people in prison, from the people in prison population. And we're encouraging them to really lead on the informal and opportunistic education to all of their peers. And so what we mean by this is they're going to lead on the distribution of the information booklets in the comic book series. And we really want to encourage the peer educators to use these resources to guide discussions out in the wings, out in the yard, anytime that they have an opportunity to just, have you ever thought about talking about Hep C? Anytime that there's a moment, we would love for them to, to just bring this up and encourage people to engage with the hepatitis services. We're also going to encourage them to host group sessions if it's, if it's suitable in their prison. Otherwise, really trying to, encourage those discussions. Encourage everyone to see the video animations, which we're going to embed in the local prison TV intranet. We'll also have some tablet computers that are going to be available. If it's suitable, we can use those in the prisons as well. And we're also going to incentivize engagement with the peer educators. So we've got, maybe some jelly beans or fruits, or maybe we can have some other types, bit beanies, cookies, things like that, to really try and get the entire prisoner population involved in the education program. So very similar for the correctional officers. We'll have those peer champions really leading on just getting everyone exposed to the education program. We will also have some, as part of the project, we will have some dedicated Hep Ed nurse educators who will be on site to really support those peer educators and get, I guess the Hep Ed nurse educators will be focused more on the healthcare providers as well, because we don't have peer champions for that group. But really have, I guess, supporting the delivery of those, of all of those resources. We're also really wanting to engage, and we do have a plan to engage with the local NGO reps at each of the sites, because we know that there are some, fantastic work that's being done by the NGOs in terms of delivering education in the sector. And so the goal of this program isn't necessarily to take over what's already being done. It's really to value add. This is an extra, these are more resources that are available, and another program that's available. So we're wanting to engage with the local NGOs to have a representative co-facilitate actually the entire rollout of the program. And that's also a really great opportunity for us to try and sustain some, foster some sustainability beyond the life of the project. So when the project actually ends, people know what these resources are about and how we should be developing them. And the goal of our goal rather is to make these resources publicly available as soon as we can. It's also, I don't have a slide on this, I don't think, but we are initially planning on rolling this program out within a research study. So we are looking to evaluate the impact of the education program, not only on the public health literacy concept, so that's the knowledge, attitudes, and capabilities, but we also want to evaluate whether it does anything about changing behaviors. So does education actually improve or increase testing and treatment rates? So we're rolling this program out initially within quite a complex, large randomized controlled trial, which was the subject of an NHMRC partnership grant, and lots of the people in the room here are CIs on that grant. And so we will be kind of rolling that out next year, and findings should be available in 2024. But in parallel to that, we're looking at trying to get these education program resources out to the sites or to the states that aren't participating in that research evaluation, because we're really just wanting to move things along and get these resources out for everybody to use. This is a huge collaborative project. It's being led, it's an initiative of the National Prisons Hepatitis Network, but it's been really led by Kirby in partnership with ASHM, who were both were really pivotal in creating and developing the resources. But we've had so much stakeholder engagement through those national steering committees and really great collaborations with the Justice, Health and Corrections organizations, the consumer organizations. And so I just really want to acknowledge all of the people who have been involved in this project to date, and also our funders, including ECA. I think that's my time. Thank you.
Thanks, Yumi. I now want to introduce Anna Wilkinson, who is going to talk to pretty well our flagship project for evaluation and surveillance. Yeah, you have a flagship program. The Progress to Elimination report that we produce each year and will continue to produce.
Thanks, Mark. So my name's Anna Wilkinson. I'm part of the evaluation and surveillance component of ECA Australia. We are presenting on the Australia's Progress Towards Elimination annual report. And I just want to note, before you all fake a phone call, there isn't any graphs in this. There's no data tables. Jackie starts to cry if I do that sort of stuff. So please don't kind of leave the room. There's no equations. None of that's actually going to happen. So you'll be okay. Just a bit of a reassurance first, even though we're talking about data. But just quietly, all the workforce development projects, I have clocked your posters and they all have numbers on them. So I don't care what you all said at the start. I won at the end because I've seen every one of them with a number on them, and I'm delighted about that. So one of the objectives of ECA was to produce and disseminate an annual report on progress towards hepatitis C elimination. This is largely a quantitative data report. So we need to think about what is in the report, how does it fit into the landscape, but how does it also fill a gap and get all the data possible. So those of you who have worked with Margaret know she's a visionary. So she employed me back to Burnett. I'm what's called a Burnett boomerang. This is my third or fourth time back. So she employed me back with Elisa and said, can you produce this report? And I said, yeah, no worries. What's in it? And she went, I don't know. That's your job. So my job was to go and find all of the hepatitis C data available that told us about how we were going towards elimination. We delivered that. We're about to deliver our 4th report next Friday. So when I made this slide, I was really delighted. I thought, oh, this is a slide that tells us about all the reports we've done. But Elisa illuminated to me yesterday that this is a history of the shit job that I've done with cover pages. Until yesterday, I thought they were all great. But apparently this is a gradient from not so great to great. Right. So the one that you can see that you might not have seen before, which is on your lower right-hand side, is actually the cover for this year. So you're getting a preview of our report that's coming out next Friday with apparently my best cover yet. Now, each of these reports has a large amount of data. So surprisingly, there is many people working in hepatitis C, all collecting data, but a little bit separately. So each report that I've done, when I count them all up, every one of them has had at least 25 separate data sources. So what we do is bring it all together so you can see it in one place. Now, this is a collaboration or a partnership between the Kirby and Burnett. So we have a breadth of editors across both institutes. So I just want to acknowledge the work that is done by these people to help me bring the report together. And I'm going to go through some of the data sources that we have available to us. Now, if you take nothing away from the report, as in you don't like graphs, I'm actually okay with that. Jackie trains me for that. I'm okay with that. But I'm going to point something out to you that even if you just picked up this report and read the first couple of pages, it's like a Refidex or a Rolodex. What do you call it? An address book. So you could actually take this and you could see, because I name and shame people, all of the people who work in hepatitis C studies and researchers, the institutes that they're at, and the projects that they're working on. So if you're ever thinking to yourself, I don't know where the data is, like who's working on this, who does this sort of work, I've created a reference list for you. So even if you just do one thing for me and you pick it up and you have a look, you can get to know everyone working in the sector who might have data that you're interested in. Now we have Access, and Jason Aslan's actually here today from the Access surveillance system. We had previously the Stop C study. We've had the Monitoring Treatment Uptake in Australia project, which you're probably aware of with PBS data. Part of that is now what something's called a national retreatment project. This year, I'm going to show you some retreatment data. We have Reach C project, who you might have heard of. Claire Bradley's here from Atlas today. The Australian Needle Syringe Program Survey you might know about. Ethos Engage. Yumi's just presented from NPHN and Beck. We have a care cascade, which is in the annual surveillance report, which you've probably seen. We have liver registry data that you may or may not have looked at before. We have the mapping project, which you probably know well. We have the stigma indicators monitoring project. We have some new data from this year from a Burnett cohort called ECA Experience. The Gay Community Periodic Survey, very well-established survey, but they actually have data relevant to the work you do, believe it or not. We have some modeling work out of the Kirby and some modeling work out of the Burnett. There's also a lot of publicly available data that you may or may not be aware of, but actually you don't need to be, because it's my job and our job at the Burnett to find that data for you and put it in the one place. We reference it all. So even if you look at the report and think, where did she get that? I'm actually quite transparent about it and I tell you where to get it. My colleague, Mark Hayes, hopefully he's online today, I'll acknowledge Mark as well, who's helping me prepare the report, was very insistent this year, slightly annoyingly, that I actually add hyperlinks to all the reference list. So even if you go to the reference list, everything is then a very simple hyperlink in the online resort that you can click on and find the data and where I got it. So if you're looking for data as well, even if you can't be bothered reading the report, flip to the back, because it's all hyperlinked in the back of the report as well. We have some specific studies, so I do look for the research studies. I am very conscious of the fact that a lot of the research and the academic papers that we do is behind a paywall. I assure you, we are aware of that. We are trying to overcome that at least a little bit with this report. So any research papers, I do include them in the report and reference them, so at least you are aware that it's available somewhere and that you could try and find that paper. And if you can't access that paper or that study, you get in touch with us and let us know. But at least you'll have a snippet of some of that data that's available for you in the report. We've organized ourselves into chapters. These are the things we think we want to collate some data under these headings to tell us about progress. I think everyone's got maybe one or two ideas of their own about how you measure success or elimination or how far we've come or where we're going next. So these are just broadly the chapters we put some data under. We're interested in new infections. We've seen a lot of testing data, which is great. Treatment's pretty obvious. We're trying to get as much data as we can on what we call these long-term outcomes, so liver disease and death. This year, we have a lot of expanded data or an expanded chapter on stigma and discrimination. A lot of the feedback we receive is that this is something that's important. And actually, if we don't understand it, then we don't understand the testing and treatment anyway. So we've tried very hard to expand the data in this section this year. We always have data on prevention because you can't forget it. So we do try and collect as much data as possible to tell us how much prevention activity is happening. We have the mapping report data because we can't forget about geographical equity. So that was always included. And we have some modeling work, which Nick is going to tell you about today. Some highlights. So folks here today, you're getting a little preview of the report that's coming. This year, what we have done is tried to summarize or simplify our findings into, we'll have a one-page summary that'll go into the report, but is also a separate document. It's got 9 squares, and these 9 squares we are going to break up into what fancy marketing people call tiles. So here I'm giving you 3 tiles today. So we've taken 9 key points from the report, 1 tile each. Some of the things we are seeing you will know about. There has been success in the reduction in new infections. There are limited places we can look for data on new infections. I know that sounds ridiculous, but it's actually true. It's hard to find out about new infections, but where we have got data, we have a decline in new infections. We can look at testing data and we know it's going down. Quite simply, it's been going down since 2016, it's still going down. But we know from the PBS data, Elisa told you yesterday, that we have at least over 95,000 people who have been treated with DAA since 2016. So this is some of the data that is coming out next Friday. Highlights of 2022 for me, because quite frankly, I'm sure you're interested in me. This year I left Victoria. I know, right? This seems like you weirdo, but we've been in Melbourne. I didn't think I'd get to leave again. So I just wanted to say this year I got to travel to the Northern Territory. My partner and I drove a motorhome. Melbourne to Darwin. I know what you should do after lockdown with your partner in a small flat is book a smaller motorhome and go on holidays with them. Don't do that. But I got to visit Uluru and it was a dream. It really was. And when in the middle of lockdown, I didn't think any of my dreams would ever come true again. But I got to visit what is outstanding place in Australia, truly an outstanding place. And I realized that I always thought you had to come back from holidays a bit rested, and I never did. And I think it's because we went a bit hard for holidays. We drove to Darwin, but I realized I probably don't need to come back rested, but I need to come back with perspective. And I think certainly if you visit this place, you come back with a much better perspective on life. We went to Cooper Pedy. This is my partner. I sent this photo to friends to provide evidence of proof of life because we were in a motorhome together. But I really enjoyed this place. I don't know if you've ever visited Cooper Pedy, but it really inspired me because it made me feel like there are still places in Australia that are pretty lawless. And as someone who likes rules, I'm well known for following rules and enforcing rules a lot. However, I found that the fact that there was this lovely town where, quite frankly, people just seem to be living their best life. I thought, you know what? I love that. I love that these places still exist. So this is to kind of show you that whilst I'm the data person, hopefully I still enjoy places without rules and without strong quantitative data. How do we use the report? Next Friday is our launch. We are having an hour webinar. We have some fantastic panel guests. If you can make our launch, come along to our launch to see some of the data and ask some questions about what does the data mean? What does it mean for my patients, my clients, my community? Explain the data to us. The report is online. The key thing is, though, we try and make everything publicly available for you. We'll have our one-page infographic summary sheet. That's for you to use. That's something you can print and you can put up in your clinics or you can use in your meetings. We have a new one-page summary that I didn't show you today, where we're going to have 3 points under priority populations. So if you work in a community organization, for example, that looks after clients who inject drugs, we have some key points about how is hepatitis C elimination going among that population. So you have some simple one-liners when you are doing your requests for funding, when you are doing your presentations, when you are talking about hepatitis C to people like me who speak in a language of numbers. You have some numbers with you. You have the stories already. You've shown us that. You can tell a patient story. Where you might not feel as confident is when you need to present some numbers to go along with that story. That's our job. We've got those numbers for you. So we can give you the resources about what are the numbers in hepatitis C and put that together with your data to sell your services and sell your funding pitches. We've got all of that available for you. That's how we want the report used. There's always ways to improve. Quantitative people always need a bit of help to improve. So we are always trying each year to get better. We do want to increase the use and the promotion of the resources available. we're always asking ourselves, do we have the right indicators of elimination? I assure you we are. We always kind of think, is this telling the story? Is this what we need to measure? Is it very good data? What's its strengths? What's its weaknesses? We are always working on that. And we know there are gaps in the data. Some we do know about, some we might not know about that you know about. So then the idea is to tell us. I can only put data in the report that I know about or I find or people are willing to share. But if you want me to go and look for something, then we can go and look for it. Again, I'd like to say thank you to all our data contributors and our editors, Mark Hayes, who's working with me on the report today. We can't do it without partnership and without everyone helping us to bring the report together. So big thanks to everyone who's helped out.
Thanks, Anna. I'm gonna, no. There are rules.
Sorry?
There are rules.
There are-
And one of the rules is you have to sit up here for a Q&A at the end. If you could, we'll do Q&A at the end
Okay.
after
Okay.
Jess and
Sure.
Nick, and we'll all talk data together.
Yeah, everyone's going to stay for that.
Exactly. So you're supposed to join us. Do you want to join now?
Yeah.
Okay. I think that's a demonstration of, when there are rules, there's, it's really Anna's rules that she's talking about as opposed to others or general rules. You think? Okay. Next, we have Jess on the go. So it's my honor to introduce Jess Howe, who, do I? I have to do something. There we are. Who's going to talk about the ECA program around liver cirrhosis and liver cancer, and how we go about measuring progress in that area. So we have Jess as a disembodied voice. Is there a picture? There she is. Hi, Jess.
Thanks, Mark. Hi, thank you. I'd like to begin by acknowledging the traditional custodians of the land that I'm talking to you from today, which is the land of the Wurundjeri people, and I'd like to pay my respects to elders past, present and emerging. And it's my honour really to speak to you today about the component of the ECA program measuring morbidity from hepatitis C. And this is really what we do, everything that we've talked about for the last 2 days towards. It's to prevent people with hepatitis C dying from liver cirrhosis and liver cancer. And so that's the work that I'm going to present to you today. Sorry, it looks like I can't move my slides forward.
Okay. Is that? I can
Can
see
you hear me, Mark?
here, but it's not changing up there.
Can someone move my slides for me, perhaps?
I can see it change down here, but are you showing your own? Yeah, you're sharing, Jess.
Yes, that's right. But I can't click forward for some reason.
Oh, okay.
Oh, there we go. We've got it moving.
Okay. Oh, lovely.
Okay.
That's a lovely. Sorry,
So
go.
Okay, so primary liver cancer, as we know, is the third most common cause of cancer death worldwide, and it's estimated to be the 7th most common incident cancer. And we know that incidence and mortality of liver cancer are increasing worldwide. Now, it has an abysmal 5-year survival rate of only 18%. We know that 95% of primary liver cancers are hepatocellular carcinoma, which is what I'm going to talk about today. But 2 to 3% are cholangiocarcinomas, which affect the bile ducts of the liver, and they're also increased by hepatitis C. Now, 90% of primary liver cancer arises in people with liver cirrhosis. And if you look at the blue incidence graph, the global map here on the left and the mortality map shown on the right, you can see that Australia really has moderate incidence and moderate mortality. So primary liver cancer worldwide is mostly caused by alcohol and viral hepatitis, and hepatitis C is the lead cause in Western Europe, in the Asia Pacific region, including Australia and New Zealand, and in North Africa and the Middle East. But we know in Australia, for example, that epidemiology is changing, and I'm going to show you some data to support that. Now, liver cancer is curable when it's detected early. And the way we detect it early is when people are enrolled in surveillance programs with a 6-monthly liver ultrasound and or a blood test for alpha-fetoprotein in combination. Now, we know from modelling work that we've done of the HCC cascade of care in Victoria that once you're diagnosed with HCC, you actually move through the cascade of care in a highly guideline-specific way, and that we actually hit all our targets for the optimal care pathway targets set to us by Cancer Council. We're pretty good at diagnosing chronic liver disease, particularly Hep C, as you've seen over the preceding 2 days, and we're pretty good at treating it as well. But where we fall down, the immediate stopgaps that are causing people to die from liver cancer, is that we are not good at measuring fibrosis risk. We're not good at diagnosing people with cirrhosis, and we're really not very good at linking people with cirrhosis to HCC surveillance programs to ensure that we pick up HCC early. And in Australia, we know that less than 40% of HCC is diagnosed through a surveillance program, and less than 1/3 are diagnosed early enough that we can cure them. So by way of background in terms of hepatitis C, cirrhosis and liver cancer, patients with Hep C cirrhosis are at greatest risk of HCC, and this risk markedly reduces but does still persist after they achieve SVR with DAAs. Now there's around a 70 to 76% reduction in that risk, but we do know that post-SVR, the annual incidence among people with Hep C related cirrhosis is still somewhere between 1% and 7% for liver cancer, which is a highly fatal cancer. This risk is increased by other liver disease cofactors, including alcohol, obesity and type 2 diabetes, and of course, the metabolic associated fatty liver disease, smoking, and of course, the presence of other liver diseases such as hepatitis B or HIV co-infection, hemochromatosis, which is not uncommon in Australia, for example. Now, we worry most about the group post-SVR who have well-compensated cirrhosis, because these people are asymptomatic. They're out in outpatient land seeing their GPs. They're not attending health services, so they've not got a good reason to remain linked to care. And they also have the most to gain from early diagnosis, because in this group, they're well enough to receive curative HCC therapy. So as part of the Ramsay ECA and NHMRC program grant, our key questions for Hep C outcomes was really to look at how we measure morbidity from hepatitis C and mortality from liver cancer and cirrhosis, and how we can reduce late diagnosis of HCC post-Hep C cure. In terms of monitoring the impact of DAAs, there's several considerations that we have to think through. Firstly, there's the lag time and impact of DAAs on cirrhosis and HCC incidence. Many of the people who will go on to develop HCC have had decades of exposure to hepatitis C. And whilst we reduce their risk considerably by treatment, there is still that residual risk. So it'll take us a while to see the full effect of the DAAs and all the hard work that everyone's doing. There are also some current data challenges which make things difficult. There's no registry of people with hepatitis C or people with cirrhosis. Hospital admissions and mortality data are very useful, but that requires accurate coding of Hep C, particularly past infection, which is not routinely done. And also cirrhosis coding is very patchy as well. It also misses those with compensated cirrhosis who don't come through the hospital system because they're well, they're not requiring admissions. Cancer registry data is modelled for the most recent few years that it's reported, and there's also no etiology data. So it makes it very difficult for us to measure the impact of things like universal access to DAAs. And finally, liver fibrosis assessment, and particularly the recording of that assessment, is very heterogeneous across Australia. Part of that is compounded by the lack of item number for FibroScan and ARFI, the two lead non-invasive ways that we diagnose cirrhosis, and also the differing availability of different blood-based biomarker scores, such as UPRI and FIB4, ELF and HEPA score. If you're in WA, you've probably had a HEPA score. If you're in Queensland, you might have had an ELF score. In Victoria, you might have got an UPRI or a FIB4. And because all of these are generally done in different ways, some of them just on a phone calculator, some of them formally reported by pathology, it makes it very difficult to collate all those data. There's also lack of uniform FibroScan report and also quality metrics outside of tertiary centres that's been identified in some centres, and also access to different fibrosis assessment tools. So the key aims of our part of this ECA network was really to monitor the trends in Hep C related cirrhosis and HCC incidence and mortality, particularly after introduction of DAAs. and to improve linkage and retention of people with Hep C related cirrhosis in HCC surveillance programs. And being a hepatologist, I had the back interest in sustainably expanding these systems to other chronic liver diseases, using Hep C as a successful prototype. So if we move first to our first aim for measuring impact of DAAs on Hep C morbidity, and some of this data is the first to come into the report this year, and also some of these studies have only just dropped data, so some of this data is very new and hasn't been published yet. So there were 4 key studies that we were running in order to fill some of these data gaps on morbidity related to hepatitis C within Victoria. The Capri study I'll speak about later. But the key ways that we measure morbidity from hepatitis C are considering the number of people getting transplants for hepatitis C, new livers to improve their mortality, the number of people developing cirrhosis from Hep C, and the number of people developing liver cancer. So the Australian New Zealand Liver Intestinal Transplant Registry study has been going since 1985, and obviously it's only of interest to us since 1991 when Hep C became a thing. And we looked at adult liver transplant recipients across all causes, and this data has then given us really excellent information about liver transplantation trends over time after DAAs. The PRECISE study is a prospective cohort study, first began in 2010 and is ongoing, collecting all cirrhosis cases within Victoria, particularly identified through FibroScan in the Greater Melbourne area. And for this study, this allowed us to look at trends in incidence of cirrhosis related to hepatitis C pre and post DAAs. And finally, the HOMA studies were 2 prospective cohort studies, the first in 2012, 2013, and the second in 2021, 2022. And these were a comparative analysis to look at the changes in epidemiology of HCC and incidence and mortality, and particularly HCC surveillance uptake and health services utilisation. So some of the key findings from these studies, first looking at liver transplantation rates due to hepatitis C. The proportion of liver transplants with more than one liver disease is increasing over time. And our work led to a change of practice to report all liver transplants that had hepatitis C as an underlying cause. Initially in all liver transplant registries worldwide, only one cause of liver disease is listed, and that's considered the first diagnosis. And that might be liver cancer, even if it's because of hepatitis C. So we led to a change in practice, collecting all data on all hepatitis C and other liver diseases. So instead of just reporting one disease, we reported all liver diseases present in the transplants. And this led to a markedly more accurate measurement of burden of liver transplant due to hepatitis C. For example, in someone who might have hepatitis B and C, they would now be listed for both diseases. Since introduction of DAAs, we've seen a marked decline in Hep C related liver transplants, both in terms of proportion and rate, overall for all liver transplants, but also for liver cancer specific transplantation. We've seen a decline in waitlisting for Hep C related liver transplant, and we've seen the first evidence of improved survival in those receiving Hep C related liver transplantation. And traditionally, this was a group that did quite poorly after transplant. So this graph here just shows the proportion of liver transplants for more than one liver disease over time, and that's shown concurrent liver diseases in blue. And you can see that proportion is increasing over time, being highest in the 2015 to 2019 era. And that has ramifications for us when we're thinking about curing Hep C, but what we might be missing in terms of other diseases in people that contribute to HCC risk. Now, this data is busy, but essentially it shows us that by reporting all diagnoses of Hep C, so if a patient has more than one diagnosis, rather than just where hepatitis C was their primary diagnosis, significantly increased the number of Hep C related transplants that were measured per year. And that's in the solid orange line shown at the top, compared with the dashed line of only primary indication of Hep C shown lower down. The second thing you'll notice from this graph is from 2016 availability of DAAs on PBS, there's been a marked downturn in the number of people being transplanted for hepatitis C, which is a fantastic thing to see. Shown differently, this shows on the left the decline in the annual rate of liver transplants for hepatitis C since the introduction of DAAs in 2016. Now, DAAs were available for a small proportion of patients once they were listed for transplant from about 2014. So that was only small numbers, but you can still see that significant impact of community-wide DAAs on transplantation rates since 2016. And on the right, this shows liver cancer specific Hep C related transplantation, and you can see that same trend. Furthermore, on the left here, you can see the decline in the number of people with hepatitis C who were waitlisted for transplantation. So less people were needing transplants for Hep C from 2016, despite the fact overall the number of people being listed for transplantation has been steadily increasing. And on the right, this shows the first data supporting an improved post-transplant survival in people transplanted in the DAA era compared with pre-DAA era, shown in the red on the top being those who've been transplanted more recently. Now, moving from transplantation to cirrhosis, the precise cirrhosis cohort had several key findings. This study is Victoria-wide, but we only show today the preliminary analysis from the St Vincent's Hospital network over a decade. We've shown that the annual incidence of cirrhosis diagnosed by FibroScan has been stable over time, but despite that, the proportion of new cirrhosis diagnoses due to hepatitis C has been declining since 2016, and metabolic-associated fatty liver disease has been increasing to take over the helm as the lead cause of cirrhosis in Victoria. Importantly, we also looked at health services utilisation and linkage to care, and among those diagnosed with cirrhosis by FibroScan, most of those, over 50%, were already linked into specialist care, and that's what prompted the FibroScan in the first place. 20% were new diagnoses of cirrhosis seen outside of the specialist setting, and they were then referred in to specialist care, which is excellent. However, 24% had no evidence of a referral being made after diagnosis of cirrhosis to any form of specialist care. And we're looking at this now across the state to see where we might be able to improve this. Now, these data, care of Erica, my PhD student, who did a wonderful job bringing all this together, shows just the proportion of FibroScans over time from 2010 to 2021 and the proportion that had cirrhosis over time. You can see essentially it's been pretty stable. We have data for 10,622 FibroScans in almost 9,000 people, and 38% of those people had FibroScans because of hepatitis C. Now, these data show, in terms of the height of the bar graphs, this shows the number of FibroScans performed for hepatitis C over time. And you can see that those bar graphs continue to increase till 2016, and then they drop away quite quickly. And then there's a big drop in 2020 when a lot of our FibroScan surfaces closed because of COVID. You can then see the blue proportion is the number of people with hepatitis C who were diagnosed with cirrhosis at that FibroScan. And so you can see that that proportion increased to 2016, but then declined over time. But what you can also see by the percentages at the top of the bar graphs is the proportion of the overall number that was cirrhotic. And what you can see from 2016 is actually a higher proportion of that reduced number of people getting FibroScans actually had cirrhosis. And this suggests that we've got better at determining who really needs a FibroScan over time. And this may be because of up-risk screening that we introduced to help triage those who need FibroScans most. So that's also an interesting factor to these data. Now, moving finally to liver cancer, there has been a marked shift in liver disease etiology from 2012, with alcohol and MAFLD now the most common causes of HCC within Victoria, whereas hepatitis C was definitely the lead back in 2012-13. Hepatitis C related HCCs declined since the introduction of Hep C cure in 2016. And again, we see this trend of a third of people with liver cancer have more than one risk factor or liver disease. Now, the proportion of HCC overall for all causes, not just Hep C, diagnosed by surveillance has declined over the last decade, which quite depressingly. It was 32% had only one surveillance, at least one surveillance scan in the preceding year to diagnosis, compared to 40% back in 2012. However, that proportion was much higher among people who were known to have cirrhosis and linked to care. In 2022, 48% presented with early stage HCC, and that is an improvement to 2012, despite that decline in uptake of surveillance. But only 38% of those new cases were able to receive curative therapy because their liver disease was too severe to offer curative therapy. Now here, this graph just shows the change in proportion of HCC cases in the two eras. The blue is the older 2012-13 era and the modern orange 2021 to 22, and you can see the clear reduction in proportion due to hepatitis C and that rising proportion due to metabolic associated fatty liver disease. Now, some preliminary data on Hep C related HCC, which was quite interesting. And this is all just descriptive. There's not been any formal multivariable analyses performed, but some key messages come through. The first was that only 20% of those diagnosed with Hep C related HCC identified as a person who has in the past or currently injected drugs. And this means this population who've turned up with HCC have not been identified as having the key risk factor that most people have in their minds when they're prompted to think about Hep C testing. So we may need to rethink how we're trying to capture people. Some of these people may not recall the risk, or it may be different risks that we're missing. There's also a younger age at diagnosis in the DAA area for HCC, a few years earlier on median. And the median time to diagnosis post-SVR was 4 years, but out to 6 years. And of course, that's the limitation of the data availability, given DAs were only available since 2016. Now, over 1/3 of these patients also had alcohol-related liver disease. And it used to be said in the old days that if you're an injector and you had Hep C, that often we didn't have to worry about alcohol. But of course, that's changed over time. And 13% of the HCC cases due to hepatitis C didn't have cirrhosis, but almost all of those had significant presence of alcohol and methyl driving that carcinogenesis. Somewhat surprisingly, 28% of the primary liver cancers we identified due to hepatitis C had never been treated for Hep C. So the first time they presented to us with liver cancer was the first time that someone said to them, you need a Hep C test and treat. 25% had first diagnosis of cirrhosis at the time of their primary liver cancer. So in 1/4 of cases, we've had no chance to prevent and enroll them in surveillance. And almost 50% of these had alcohol as a cofactor. Only 32% of Hep C related liver cancer was diagnosed through surveillance. And this compares to 52% in 2012-2013. So that means we've reduced the number of people we're successfully linking into surveillance for liver cancer in the DAA era compared to previous. And alarmingly, 2/3 of the people diagnosed with Hep C related HCC post-SVR were not receiving surveillance. So they've been linked to care enough to get a test, be told their diagnosis, get their treatment, and then we haven't been able to retain them in the necessary care to prevent death from Hep C. But we've seen some positive things, that there was an increase in Hep C related HCC diagnosed at early stage. Now, how much of that is due to surveillance is probably unlikely. It's probably more related to changes in the technical expertise of our radiology. We're able to pick up liver cancers earlier and earlier now, but also it might be that DAAs are improving liver function to the point where people are at an earlier stage of liver cancer as well. So some of those data are sombering, but I think it shows us that we are making some really good gains in terms of reducing the absolute numbers of morbidity related to hepatitis C. Now, the second part of our study was really looking at improving linkage and retention in specialist care. And there's 2 key projects that are underway at the moment. Unfortunately, because of COVID, the interventional components are starting in January and February, respectively, of next year. So we'll have more data next year, but unfortunately not at the moment. Now, the PRECISE study is a pre-post intervention study looking at an intervention to automate notification of GPs and patients of cirrhosis, automating information about cirrhosis sent to both the patients and GPs to help inform them how they can and empower them to manage cirrhosis and HCC surveillance. But we're also automating specialist liver clinic appointments and linkage to HCC surveillance programs for these people, with instructions how they can opt out of that, of course, and choose their own providers, but really to try and stop that gap where people are diagnosed and then got lost to the ether and never come back to us. The second is the Caprice study, which we're performing in collaboration with St Vincent's Pathology. Here we're looking at calculating on a population level and reporting on UPRI scores and FIB4 scores for all adults who have a liver function test and full blood count testing event together. And what we want to do by this is really to raise awareness of potential risk for cirrhosis that might be missed in people who don't fit the standard criteria that people are aware of for testing for viral hepatitis and other causes of liver disease. And what we do is in the reporting that's provided by St Vincent's Pathology, it's itemised as a separate test, even though there's no cost involved and no extra actual testing being done. And that allows it to be searchable in a GP's electronic medical record, but also in hospital medical records as well. So it's easy to find again for people when they need that information. We also provide information. St Vincent's Pathology has automated web links to bring them to information about liver disease, including viral hepatitis, to inform people, the health worker who's ordered the test, of what to do next, and a link for FibroScan for those who have a high reading. So in terms of the progress and the timelines we said of what we set to achieve this year, we've been fortunate that we've been able to achieve all of those milestones, and we look on track to achieve the final milestones that we'd set for December. And for 2023, we've also got several milestones, basically the HOMA study final follow-up, Caprice study and Precise studies completion, which will be very exciting to see those data. In terms of outputs, we've had several papers, and really, again, I'd like to highlight the work of my PhD student, Erica Flores, who's done most of this work. We've had some success with grants, but some of the important translations into practice are to have the first morbidity data coming into the ECA progress report, which is exciting. The changes in practice about how we record viral hepatitis and link that to transplantation, so we can be more accurate about measurement of morbidity related to hepatitis C and other diseases. Our work informed the Hepatitis B Australian Consensus Statement, even though it's not related to hepatitis C per se. And the FibroScan report documentation and mapping we did as part of this approach for Precise has then led to changes in practice in terms of how FibroScan results are recorded across all networks now, to bring more uniformity, recording of quality metrics, and also ensuring that people can find those results. They're not written on a scrap of paper and get lost in a paper record, but actually are searchable in either a GP or hospital medical record for future. So in conclusion, DAAs are preventing Hep C related morbidity. And I think all of us in the room can be really excited that the work that we're doing is starting to really show fruit. So Hep C related liver transplantations declining. There's been a decline in Hep C related cirrhosis incidence, and HCC-CV is no longer the lead cause of liver cancer in Victoria, and likely for Australia as well. But there are some more work to do. Those already living with Hep C cirrhosis are being left behind, with diagnosis of cirrhosis and linkage to care remaining low, and the uptake of HCC surveillance actually declining in the DAA era compared to the pre-DAA era. So we have to work harder to improve that last step. To reduce HCV mortality and increase cirrhosis diagnosis and linkage to care, and HCC surveillance is absolutely essential. And I'd just like to acknowledge all the collaborators, particularly in the Melbourne Liver Group and the VCCC, and of course St Vincent's and Burnett for this work, and Cancer Council Australia, but particularly my PhD students, Dr. Erica Flores, who's done an incredible work on all these projects, and Dr. Lauren Anderson, Anne Farrell, and Dina Musa also, who've been assisting with some aspects of the HCC HOMA work. Thank you very much.
Thanks, Jess. It was amazing work. It continues to be incredible work. Really hard stuff to measure, and has, really been an Achilles heel in some of our surveillance around morbidity and mortality outcomes related to hepatitis C.